All right, well, we'll go ahead and get going here, everybody. Good afternoon and welcome to this, our final session in our Introduction to Telehealth ECHO series in partnership with Renown Health. Really happy to have you all here. Again, welcome. We'll go ahead, we'll do introductions of everyone, our hub team and subject matter experts then on to you joining us. So I am Troy Jorgensen, I'm the program manager for Project ECHO Nevada. Welcome again today. Mitchell?
Hi, everybody. I am Mitchell Fong, Director of Telehealth at Renown Health. Glad to see you all continuing the sessions with us in our journey through the 4-part series, but very excited to talk today a little bit about where we've gone with COVID, during COVID, post-COVID, and excited to share some of the future enhancements that I think technology can bring to the healthcare industry. So thank you all for joining.
Thanks, Mitchell. Crystal?
Hi, I'm Crystal Larson. I'm a telehealth coordinator with Renown. I've been in my current role for about 3.5 years, and I'm also happy to be here today.
Thanks, Crystal. Gary?
Good morning, everyone. Gary Beck. I'm the Director of Rural Health Services here at Renown Health. Been in this position for a little more than 3 years and have had an extensive background in rural outreach through all my years here, including many years in cardiology and then the past years serving our rural partners in my position now. So I'm pleased to join you and thanks for joining us.
Thanks, Gary. Yeah. And Jessica.
Hi, everyone. My name is Jessica Thompson. I'm the manager of the telehealth department here at Renown. I've been in this current role for about 1.5 years. My background is in nursing and primarily worked in rural healthcare.
Thanks, Jessica. Good to see you today. All right, our team member, Sneha.
Hi, everybody. My name is Sneha Sharma, and I'm the program coordinator for Project ECHO Nevada.
Alrighty, that's our team here today. Now on to you joining us out there. Neil, if you're first on my screen, please go ahead.
Hi, everyone. My name is Neil Chio. I work for a company called Genentech, and one of our purviews and new things that we're trying to work on and learn about is how telehealth is affecting the industry and how we can help support those efforts. So I'm glad to be here and thank you for the session.
Thanks, Neil. Amber?
Hi, I'm Amber Batchelor. I'm the program director for the Nevada Coalition to End Domestic and Sexual Violence, and I'm here to learn more about telehealth.
Thanks, Amber. Good to see you again today. Deb?
Hi, my name is Deb Arno. I'm a psychiatric nurse practitioner in the medical schools, behavioral health clinic, and I'm doing primarily telehealth in the state rural clinic system. Thank you.
Thanks, Deb. Welcome back today. Dr. Greenberg?
Hi, my name is Leslie Greenberg. I am a family physician. I teach at the family medicine residency here in Reno, and I am here to learn where are we going in with this and how can we incorporate this into me teaching new doctors.
Thanks, Dr. Greenberg. Welcome again today. Charlotte? Go ahead.
Infection control at Highland Village, and I'm also a student for psych nurse practitioner.
Thanks, Charlotte. Welcome today. All right, the screen name is just a period. If you could unmute and introduce yourself, please.
Hi, Amy Barney, Ely, Nevada Economy Health Clinic, Family Practice, Occ Health.
Great. Welcome today, Amy. Good to have you.
Thanks a lot.
Dr. Bien?
Hi, my name is David Bien. I am a hospitalist at William B. Ryrie Hospital in Ely, Nevada. Just to clarify my position, I am pro telehealth.
Thanks, Dr. Bien. Always good to have you. All right, and Seema joining us. Seema, if you could unmute and introduce yourself, please.
My name is Seema Rathore. I work for Comagine. I'm in Portland, Oregon. I mostly work with Medicare contracts, and telehealth is one of them. Thank you.
Thanks, Seema. Great to have you back with us today. Alrighty, so we'll turn it over then to Mitchell for our presentation. Always want our sessions to be interactive though, so feel free to unmute yourselves or write into that chat box if you have any questions comments, thoughts, concerns, anything like that?
Awesome. So I think the screen should be sharing my slides now. Are you guys able to see that well?
Yep, everything looks good, Mitchell.
Okay, perfect. Thank you for that confirmation. So really excited to have pro telehealth people on the line. First of all, appreciate you all and really excited to see what we can do here together in the near future. But really taking us through this kind of 4-part series, we're going to start with our usual disclaimers here that everything you hear, we're going to use Renown because all of us presenters work at Renown as an example. But what we share is our opinions, our thoughts, and our predictions, or maybe I should say my prediction for what's going to happen with telehealth in the future. So please don't hold Renown accountable. Hold me accountable if that's wrong downstream. So with that, we've already met Gary and myself. We're really excited for today's content. We're going to walk through very quickly a recap of the first 3 parts, a little bit of what were the barriers pre-COVID for telehealth, how were they addressed during COVID, and then furthermore, what do we think will be the long-term impact of COVID? With that, Gary will also give a little update on national emergencies that are going on with all the fires, the hurricanes, et cetera, what impact that may have. And we'll transition that into a prediction of the future of telehealth, and we'll open up for Q&As. And again, as Troy said, raise your hand, post in the chat, interject as you see fit. We want to make this as valuable for you as possible. So we would love for you guys to add your questions in the moment. We like having that active dialogue as we're on those topics. So jumping right in, we've started so far, part 1, we talked about what is telehealth, what are some of the different modalities between synchronous and asynchronous, direct to consumer, clinic to clinic, hospital to hospital. We talked a little bit about why it's so important to address social determinants with the focus on rural health, access to care, barriers to broadband, some of those types of challenges. Then in part 2, we talked about starting with a strategy, a vision, a goal, a value proposition, to then refine that and start thinking about how do I select the right technology and the right partner in that space. And finally, last week in part 3, we talked about that next step of now that you've selected your technology and you have this vision, how do you implement, how do you train, and how do you ensure that you're remaining compliant in a way that you're continuing to improve the program, making something that's scalable yet sustainable over time to ensure we're creating access for the population today and the future populations to come that will need that service. So I'm going to pause there and ask, are there any topics related to these areas that you want to get more clarification on, or you had any questions as a group? All right. I will jump forward then to pre-COVID. What happened? Why did we not use telehealth before COVID? And so there's a myriad of different areas that were barriers or restrictions for limited use of telehealth. Primarily, a lot of these are based on our national federal CMS policies, but statewide, it varies. And a majority of states had either some or all of these barriers as well. So the first one is geographic restrictions for the location. So with that, we had a restriction of the providers delivering the care had to be in an urban hub, and the patients had to be at a rural Medicare clinic, which meant they couldn't do these services from home from the patient perspective. And additionally, the providers needed to be in an urban setting. Why is that a barrier? Well, when we think about that, and I'll use Renown as an example, our providers that work out of our rural clinics are actually our providers that have the most access and capacity to take on new visits and more patients. Unfortunately, with this restriction, they weren't able to deliver care to other rural communities, even though that's the same providers that may be delivering care at our Renown clinics on a different day of the week in an urban hub. And so that was one of those restrictions that limited the adoption and use of telemedicine pre-COVID. Originating site reimbursement, and what you'll see on the next 2 is just reimbursement amounts. Reimbursement parity were low, and so the ability to get compensated for a service that's done at an equal level virtually versus in person, you would get reimbursed lower if it was done virtually versus in person, even if it was the exact same service and the same billing code that you wanted to try to use for that level of service. And so there was this lack of parity between visits that were going in. Asynchronous telemedicine and direct-to-consumer telemedicine, for example, were not reimbursed or reimbursed at extremely low rates that couldn't compensate the cost that it took to deliver that care. And I think as we see a transition towards value would be some of the waivers and responses that we've implemented as a country that has alleviated some of these needs and restrictions. We've talked a lot about the broadband connectivity and getting that connectivity directly to the patients or to those settings. And then furthermore, the cost of equipment. Previously, you required specific special telehealth equipment. You couldn't just use a webcam or a laptop and deliver the same care. But over time, we've gotten to the place where technology is so advanced that using a laptop's webcam is essentially at parity with some of these higher quality telehealth specific devices. And that just goes to show the level of engagement as a country we've taken in this remote work, these video meetings, and how consistent and how much of a requirement it is now to be able to have high quality video meetings like we're having here today. So those were some of those big picture items. And the last one is culture and stigma. The reluctance of providers to say, I don't know if I can deliver the same level of care. Patients as well, not sure if they'll be able to get that same level of care. And I think with the requirement with COVID to be seen virtually, we've seen a lot of that stigma be addressed. And I'll get to some data that speaks to that a little bit here. But some of the initial responses, there 1135 waivers are what we implemented across the country at the federal level from the CMS level. That expanded the code set to over 100 different additional codes for either a temporary expansion or over time has become a permanent expansion, which I'll talk to on another slide, which of those are permanent, et cetera. They created reimbursement parity. So if you were then going to deliver a care to a patient, A, you can deliver it directly to a patient on their mobile device at their home, but then B, we'll also reimburse that as if it's an office visit. So that helped really expedite the level of adoption from providers because they were able to meet that need of keeping that patient isolated because of COVID, but still getting paid for the level of care that they need to deliver to that patient, whether it's a primary care visit, a specialty visit, et cetera. We saw state licensure relaxation where today with the waivers, you don't need to be licensed necessarily in the state that the patient is and the provider is. Well, that's a telemedicine rule without the waivers. The waivers have allowed that to be dictated on a state-by-state basis. So some states like Nevada, as long as you're licensed in the state that you're actively providing care in, let's say that's Arizona for a provider, with these waivers, we allow you to deliver care to our Nevada patients so that you can deliver and not delay care. There's certain states like California that are saying, well, we're not going to allow you just to deliver care because you have a Nevada license, but we will have an expedited process for an emergency temporary license due to the pandemic that you can apply for so you can deliver care across state lines without a full California licensure. And so that every state has a different level that they've taken that relaxation to, but it's really expanding that ability to share providers across states. And particularly for those patients like ours in our community, that we're a border community, we have so many patients that live in California, but historically drive to Nevada for care, at least us in Reno. And so being able to continue the care for those patients without requiring them to drive to our facility was a challenge. Those are some of the flexibilities that have been implemented. We saw the HIPAA waiver removal for video, which basically meant that you won't be penalized if you use a platform to deliver the video visit that is not HIPAA, does not meet the HIPAA security requirements. And so with that, we saw a lot of people using FaceTime or Zoom, general Zoom, not Zoom for healthcare, because they do have two different modalities, one that is HIPAA compliant and one that's not. So just a few of those different modalities that assisted with creating that access up front. Over time, they've looked at that and started to make some decisions about what should be permanent or not, what I'll get to in a later slide. But then there was a myriad of grant funding opportunities from national and statewide entities. FCC had a lot of funding, over $250 million in funding for broadband, for infrastructure, for technology. So I think a lot of that really helped ignite this telehealth movement. What we saw with that was an impact of utilization spikes really around when there was spikes in COVID. because as we needed to be a little bit more sensitive with COVID, we had to be more isolated. So we're seeing patients use virtual services. And with that, we've seen a huge adoption of the technology, a removal of the stigma. And just as a sample, this is Renown data. I know it doesn't show the volume, the actual number, but you can see the trend. And I think that's the important part here is you can see that in the springtime of 2020 at the onset, huge spike in virtual utilization. As we kind of stabilize and we saw COVID decrease in our community, we saw that drop and get towards baseline, not nearly low as far as baseline was in January, February pre-COVID, but definitely a steep decline. And then towards the end of the year, in that winter time when we had the second spike, you see the virtual utilization follow that trend. And I suspect here we'll see something very similar here in the September time as we're kind of having another spike here. I think we're a little bit more prepared for how to deal with COVID in office and in person as well now. So it might not be as steep of a spike. But around the nation, what did we see? I like to look at this bottom left graph here, this graphic, I should say, that shows that looking time over time, the exact same questions, how many patients are using telemedicine? Well, it went from the onset of COVID of about 19 to 20% of patients up to over 60% of patients. That's over 3 times the percentage that we've seen use telemedicine at that time. Looking at the top here from 2020 to 2021, majority of patients were hesitant to use telehealth in 2020, but a whopping majority want to continue to use telehealth in 2021. The next bullet points with quality, very similar story. And as we continue to look at it, we just see this preference for patients is moving towards the ability to want to use virtual if possible as necessary. So I'm going to pause here and ask any questions on this data, any comments that you guys have at this point.
Yeah, Neil, please, or actually real quickly, let me get to Dr. Bion's comment from earlier and then Neil. So Dr. Bion just sharing his experience in Ely, saying AT&T charges almost $70 a month for 5 megabyte service that often drops connectivity.
That sounds terrible. We'll have to see what we can do to work together and see if we can get some grant funding to build some better infrastructure out there to support that. It's not good if that's consistently dropping. Would love to see what we can do there.
All right, Neil, please go ahead.
Yeah, thanks again, everyone. I just was curious as I was listening to Mitchell present, is there a benchmark around the world or even across the country of how telehealth is, kind of coming around, being utilized? Or is that something that you guys and kind of the whole industry is sort of pioneering and trying to figure out, what that benchmark looks like?
Yeah, I'll say that I think it's a little bit of a work in progress, and it depends what service area you're talking about specifically. The biggest one we typically tend to hear is outpatient virtual care utilization, because that's kind of the best apples to apples comparison. And what I've seen around the industry, again, it's moving targets today, is a 20 to 30% rate of outpatient visits being done virtually. So about a quarter of your patients done virtually is about what the gold standard is right now. And that's for companies that are really kind of in a hybrid model moving towards that value-based care. I think that number will kind of shift and adjust as we see the appropriate utilization and we look at quality outcomes over time. But what I've read from multiple different sources is anywhere between 20 to 30 is really a reasonable target. I know there are some that are value-based organizations that are a little bit more aggressive, like Kaiser, for example, requires that over 50% of their outpatient services be done virtually. So every organization has a different mix. What I've heard, about a quarter is kind of a standard target.
And thank you, Mitchell. And would you say that around the world, it's similar type of adoption or different type of healthcare systems?
Yeah, I don't want to speak for all other countries because I'm not as knowledgeable, but I'll say from what I've seen in global events that I've been on is that this trend of moving towards virtual is consistent around developed countries. Obviously, in some of those third world countries, there isn't as good adoption utilization, but it's really funny that you say that because one thing that I find very interesting is in those third world countries, they might not have a roof on their head, but they have a cell phone. And if they have a cell phone, that means there's an opportunity to bring healthcare to them. So I think that for me, from a passion standpoint, I think we might be able to explore delivering care in that modality further downstream as we look at some of those third world underdeveloped countries. But I know today from developed countries that I've had opportunities to hear presentations on, it seems like the general move is in the same direction.
Right. Thank you very much.
Absolutely. Great
Let me just add, I came across an article yesterday and it just adds to what Mitchell has said, but despite the telehealth dwindling from last year's peak, the article said many provider organizations are looking to expand their virtual care services to better manage patient population and while keeping costs down. And I think because of the pandemic, I think all of us in healthcare are looking at ways that we can reduce costs because of the financial strain that we've incurred over the past year. They say the top 3 areas for future telehealth expansion is chronic management, of course, behavioral health, and urgent care. So I just wanted to add to what, and it was timely that I saw this article yesterday. So.
Awesome. Thank you, Gary. No other questions. We'll continue through here. And so what were some of the permanent changes? So CMS expanded permanent codes to the telehealth approved list, over 100 of them. So that's really good. What they've also created is a category 3 level of codes for telehealth specifically. What that means is that those category 3s, they're temporary expansions during the public health emergency, but they can expand beyond. And that's because they're collecting data to determine the evidence behind making these permanent or not. And so there are codes that are permanent with the intent to remove them when the pandemic's over. There are codes that are permanent that will be there forever. And then there are these codes that are temporary, waiting for more data to determine what are the codes that should be kept moving forward. So some things that fall within that are low acuity ED visits. Can we still do those virtually? Or only urgent care visits going to be reimbursed virtually? SNF discharge management visits, psychological testing, and then the category of direct supervision. Historically, it's always been direct supervision when we think of remote monitoring. They rolled it out and expanded it so it could be indirect supervision. So anyone under the care team essentially can do those monitoring tasks. And there's consideration of should that be permanent or will it need to revert back to direct supervision of the provider. In Nevada specifically, we've seen SB5 as a rule to expand telehealth with updates that it was pushed. I think it was July or August of this year. So it's been recent. I think it goes into effect in 2022. But really it's including asynchronous modalities, creating better reimbursement parity, expanding the geographic. So addressing some of those barriers that we talked about on the prior slide. So when we really think about what's the impact, why is this important? Well, the more new services there are that are reimbursed, the more new ways we can innovate because we can expand on some of those delivery mechanisms to create new modalities to augment the way that we're typically delivering care and really expand our creative thoughts from brick and mortar walls to anything. With that, we're going to see a lot of home service expansion and mobile care teams, whether it's mobile nursing, community paramedics, as Gary said, remote patient monitoring, hospital at home, bringing EKGs, diagnostics, labs to the patient through mail kits. Those are things that are actively going on today. So I think that'll be really interesting to see, particularly in rural communities. Can we have a model where we send them these tests and they send them back so we can have a virtual visit where we're still having that full capacity, potentially with integrated vitals in their lab and imaging all done from home. And so I think that's an exciting opportunity downstream. We look at reimbursement and the value-based implication. That parity is so vital for those still operating in a fee-for-service world. But as we look at value-based implication, the expansion of these services will allow us to save windshield time, potentially save overhead, and deliver the right care at the right time from a patient perspective. The more timely we can expedite that care and bring it directly to the patient, the more likely it's going to have a meaningful impact on that patient's life. And really, I think with all of this, we're going to continue to see a host of funding opportunities, whether they're federal, whether they're research oriented, whether it's donor funds that are extremely interested in this. And you're going to see a lot of tech companies that get into this space that are looking for joint ventures, potentially having funding that they can bring to the table to partner with the health organization to validate a product and idea. So that's kind of what I see as the impact of policies here. And before I turn it over to Gary to talk a little bit about natural disasters, let me pause again to see if there's any questions or comments. Awesome. All right, Gary, I'll turn it to you and just tell me next slide when you're ready.
Thank you, Mitchell. So either by attending the series that we've provided, or whether you've incurred your own experiences on your own, I think we've all witnessed how telemedicine has played an essential role in what could be considered a disaster, which is the COVID pandemic. But however, what we have witnessed recently that has occurred in our area, much of even across the world, Mitchell and I thought it would be of value to you if we briefly touched on the role of telemedicine in natural disasters. With the numerous and ongoing wildfires in our area, the impact of Hurricane Ida on Louisiana and the southern and northeastern states, as well as the recent earthquake in Haiti, we realize that telemedicine can and will play a vital role in wherever natural disasters such as these will occur. So some leaders in the field have now referred to telemedicine that is applied in disasters as disaster telemedicine. And it's been pointed out that one of the frightening features of climate change and natural disasters is the way that they can compound risks to public health. We know that people living through these endure severe mental and emotional stress. There's always an increased risk of heart attack and stroke as a result. Think about those people that have been notified that they have to evacuate, and sometimes, with very little notice whatsoever, and then come back to the home or the dwelling, a structure, business that's been completely resolved. There of course is a lot of stress that these people have to deal with. In some of these areas, they find that their local hospitals and clinics and pharmacies have all been closed or without power. And now might be the best time to just kind of digress a little and talk about how the wildfires in our area have impacted people that maybe we know, or several of our rural hospital partners in our own service area here. So earlier in the summer, we had the Beckworth complex fire to the north of Reno, and it was right around the Portola, Beckworth, California area. And then there was the Tamarack fire, which was to the south of Reno, that started around the town of Markleeville, California. And I will say, although there was a significant number of structures that were destroyed and evacuations that took place, both Eastern Plumas Healthcare District in Portola and Carson Valley Medical Center in Gardnerville remained open and providing full services throughout the time of these fires. The next wildfire to mention is the Dixie Fire, which continues today, and as of this morning is only around 58% contained and has apparently grown to approximately 927,000 acres. And as you can see from this photo, the Dixie Fire tragically destroyed much of the historic town of Greenville, California, with nearly 75% of this community reduced to rubble. Greenville, at one time, this goes back quite a way, so it tells you how long I've been in the area, and serving the rural communities. But Greenville at one time had a very small hospital there called Indian Valley Hospital, and it included a medical clinic and a skilled nursing facility as well. But that closed down many years ago. And so fortunately, no healthcare services in Greenville were disrupted. But fire stations, the fire truck was destroyed. So, obviously they had, just a lot of disaster to that area and to those residents of the community. Unfortunately, there's a little bit different story for the town of Chester, California, which is a little bit northeast of Greenville, and Seneca Healthcare District in particular. On August 4th, Seneca Healthcare District evacuated all remaining essential employees and closed their ER. the skilled nursing facility residents were temporarily relocated to Chico, and they decided to, along with those patients, they took 16 of their nurses and took them over to that area to take care of them. Now, here's a prime example of where remote patient monitoring might have been considered. I haven't had a chance to talk to the facility to see if they had that capability, but keeping in mind that these residents in the skilled nursing facility needed care, and it would be best by people that had been taking care of them, they made the decision to take those nurses over to the Chico area to provide that continuity of care for those patients. I haven't heard whether those patients are back in the facility or not. It's funny, I had a conversation yesterday with a nurse that works at Renown, but worked in Santa Rosa when they had their big fire. And she said there was several of the skilled nursing facilities in Santa Rosa that just took their patients over to the evacuation area and let the patients off there. And she said it was just a disaster because they had no capability of taking care of these patients. But hopefully in time we've learned from those mistakes and realized that telemedicine really could play a role in taking care of those patients. Meanwhile, again, getting back to the Dixie Fire, while it was spreading in Lassen County, it did have an impact on Susanville and Banner Lassen Medical Center in Susanville. Lassen County itself experienced numerous power disruptions, and as a result of their primary power source in the county being damaged. Then the county's backup power source also failed, causing what was a widespread power outage and disruption of critical services in Susanville, including Banner Lassen Medical Center, a skilled nursing facility in Susanville, an assisted living facility in the county's water system as well. I do know Banner Lassen Medical Center was and has been on standby alert for evacuation, but fortunately so far they haven't had to evacuate. And lastly, just a brief note on the Calder Fire, which is over in California and impacted a lot of that area along Highway 50, and certainly we've all been aware of what's happened with South Lake Tahoe and Lake Tahoe with the evacuation there. But on August 30th, Barton Memorial Hospital, along with all the residents of its skilled nursing facility and acute care patients, were evacuated. 16 acute care patients and 36 skilled nursing facility patients were transferred to various regional medical centers and facilities. And I do know, in talking to our transfer and operations center, they received a call at 3 o'clock in the morning on Monday morning that asking for 8 of their acute patients to be transferred to Renown, which we were happy to be able to accept. And then earlier this week, on September 6th, the California Department of Public Health approved the reopening of Barton Memorial Hospital. And they just provided an update yesterday indicating that virtual and phone visits were now available for most service lines. And MyChart communication was also available for all medical service lines. So again, you see how they're continuing to provide care and services for their patients and how telemedicine has played a key role in that. So let's just get back to the PowerPoint presentation. But point 3, people who experience new and urgent healthcare needs. And there's been a lot of talk about, the stress on people impacted directly from it. But if you consider many of us ourselves have been impacted by the smoke. And so, those small particles get into our lungs and can cause a lot of damage. And so there's a lot of health issues involved with that. So it's not only people directly impacted by the fires, but it's, even people afar from those areas that have been impacted by the smoke. The next, number 4, people leave their homes early in a rush. They forget about medications. They forget about medical equipment. Many people are on medical equipment that require power. They leave their medical instructions behind. So oftentimes, it just provides a lot of concern with their health and well-being, when they're evacuated or when they're impacted by these fires. The healthcare system itself may not be functioning 100%, as we saw at some of these hospitals. Not only did they close, but in some cases they lost power. And so there is a greater demand for healthcare resources at the time. And I think what we're seeing across the country is there's less capacity at this time. And a lot of it can be attributed to the surge that we're now seeing with the Delta variant. We also note the staff shortages that many of us are experiencing as well. Like I said, what's the damage that has been done to some of the local hospitals or clinics certainly does not help with this. But as Mitchell mentioned earlier, it is important to note that digital health is not going to work for everyone. And, like Dr. Bayan said, access to broadband is lacking. He has a hard time getting a signal in Ely, and think about some of the other rural areas that have a hard time getting the signal. But we do know that a large number of people have smartphones. So I think the goal should be to create phone-friendly software to open up healthcare in the web so that more people have access rather than, being dependent upon power and electricity. We'll have, our smartphones to be able to help us stay connected to health and allow homebound people to get the care they need where they want it. Next slide, please. So I think it's important when considering natural disasters that we look at new ways to increase access during care, to provide care during these disasters. And I think, we've certainly seen and witnessed direct-to-consumer telemedicine and the role it plays. It can reduce demand on local emergency departments. And so those patients going into the emergency department is where they need to go to get a higher level of care. Oftentimes people can get the care they need, via telemedicine or by the phones. Next point is provides care for minor non-emergent acute conditions. Certainly for our rural patients, that it helps them avoid travel, especially that in what can be considered unsafe conditions. They can get any kind of medical advice in a timely manner. These physicians and providers can assess urgency of the condition and then triage appropriately based on some of the medical decisions that are being made. Patients can get prescription refills. I mean, oftentimes, we leave the house if we're evacuated, and this happened to me personally in November. We left the house because of a fire in Reno. I forgot all about my medications. And so I think it just makes you realize that, if you're away from your home for a while, that you certainly will be able to have access to your refills. And then we know that anytime that we can reduce time to encounter, it will improve the outcome. And that certainly is going to be a goal. Local government and federal agencies can utilize telehealth tools to develop emergency response apps to communicate with 9/11 operators and FEMA workers. And I think what we've seen not only through COVID, but what we can see through, possibly new topics in the future is a knowledge sharing opportunity. And, I again commend Project ECHO Nevada for having the COVID talks throughout the COVID surge and providing a lot of people with a lot of good information. And hopefully that will continue not only with disasters such as COVID, but natural disasters. And then, first responders, certainly having telehealth equipment out in the field is going to be of value, especially with an unexpected crisis. The only thing that I'd like to summarize is I think what this points out is that physicians and healthcare personnel we really should continue to develop skills in triage, urge capacity, management, ethical, legal considerations and issues surrounding disasters and natural disasters, organizational interoperability, and then telemedicine itself to ensure not only their personal protection, but our patients' protection as well for the future. And so with that, I will give it back to Mitchell unless anyone has any questions of me. Thank you. Go ahead, Mitchell.
All right. Well, thank you, Gary, for that update. Really appreciate that. Kind of piggybacking off of what Gary was talking about, I wanted to share a little bit of how else can we use telemedicine and what's being done that maybe not everyone knows about, whether it's active live today, in pilot phase, or in development. I want to share what I find to be extremely exciting and interesting new use cases at telehealth. So one of them is the emergency triage, transport, and treat model, which essentially can assist with, today, paramedics only get paid, or ambulance only gets paid if they transport a patient to the ED. But we all know that a lot of times they get called to the house or to the location. The patient doesn't need emergency level care. It could be urgent care. It could be a virtual visit that can handle it. It could be a prescription refill if it's a behavioral health issue. And so sometimes directing that to the ED is not the appropriate use, and it's not a good use of the patient's time to get them the right care. And so what this program allows is to say, hey, we can reimburse community paramedics now if they have a telemedicine backend to an ED provider. They can still do their EMTALA emergency room screening through telemedicine to triage the patient and then determine, do you need to bring them to an alternate care, like an urgent care instead for the right level of care? Do they truly need transport to us in the ED? Or is it something that you as a community paramedic can treat them on site with physician oversight? And if that's the case, since we're on telemedicine, I'll oversee you doing that procedure. And now we can treat the patient where they are in the moment instead of transporting them, incurring that high cost, and then waiting in the emergency room, being exposed to other sick patients to get that same treatment. So that's one exciting way that community paramedics could be used in telehealth for emergency responses or other ways downstream. So I just wanted to throw this example in and say REMSA is actually one of the participants in the CMS pilot initiative right now that's evaluating this. So let me pause. Any questions, comments on this really quickly?
Hey, Mitchell, it's me again. I just wanted to be clear, is this in play right now?
This model is in play right now through the CMMI office, which is the CMS's Office of Innovation. So what they essentially do is roll out new services in a pilot phase. They offer it as kind of a grant. So the kicker here is a 15% booster for the providers delivering the telemedicine service and the ability for those ambulances to get reimbursed even if they don't go to the ED, which is a change from the current logic. That's currently in a pilot, and that'll go on for I think 2 or 3 years to collect data, and then they'll determine, is this a good model of care that we should make permanent through CMS? So today it's live in that CMMI pilot phase where you have to apply to be one of those members. But REMSA is our local in Reno, our EMS agency. They're actually one of those participants nationally that are doing this.
I can share a little bit of something about that as well. So here in Neely, we did that program for about 6 months to a year. So we got a grant and we used it. We had somebody do this community paramedic paramedicine program. And one of the classical stories that is given that there was an example of success is that this doctor couldn't figure out why the blood sugars of this patient was all over the place and couldn't essentially manage. And this patient would eventually come to the emergency department frequently for this issue. What the community paramedicine program did is they went there and it was just as simple as a malfunctioning glucometer. No, it's not something that the doctor would have figured out. People don't carry their glucometers. They leave it at home and come to the doctor's office. So it was one of those situations, is one of the classical stories we like to give out and say, okay, this was one of the great benefits of the community. It was something as simple as that. Doesn't require a lot of medical knowledge or anything like that, but they were able to find out what the problem was. So and so this I'm pro that as well.
Thank you, Dr. Bean. Love what you're pro for, and we support the same things. And thank you for sharing that example. That's awesome to hear that. So I'll continue moving. I'll try to go a little quicker just in the interest of time here. But what I'm going to show you in the next few slides are what I believe are very cool and interesting new different use cases. So we talked a little bit about the shift to home diagnostics, home infusions, home imaging, EKGs, labs, but this continuous monitoring in a passive fashion. I know we do it today, and we've started to. What you'll see on the left, that's a BioIntelliSense, and I didn't get rights, but I just found pictures on their website, so I referenced them. But essentially, that's a button that you stick on, you wear it, and it then captures respiratory rate, pulse rate, skin temperature, and the position of the patient. So you can see, are they standing, are they sitting, are they walking, are they laying on the right, are they laying on the left? And so that ability to passively wear that and get that, particularly when we're looking at the nursing shortage that we see across the country today, that's going to allow us to empower our teams to say, hey, in an inpatient setting, we can actually have a larger patient to nurse ratio because we have technology like this that will proactively flag us and give us these smart alerts as to what's going on and when we need to intervene. On the left, you see one that's very similar with the continuous pulse ox. We use this device actually for a lot of our COVID patients to send them home with this. We send them with oxygen support, but now we get real-time, minute-by-minute readings on what's your oxygen levels, what's your pulse rate, your respiratory rate, your temperature. And so we have alerts and algorithms built in to help us monitor that patient, where we can proactively reach out to say, hey, your oxygen levels are dipping below 88 right now. What's going on? Are you actively walking? Is your oxygen connected? Does it need a refill? Are you feeling any of their symptoms? So we can determine, do we need to get a doctor on the line with them? Do we need to send out community paramedic? Do we need to arrange a transport? And so this is very interesting to me to think about different use cases that we have. And to Dr. Bune's point, I love that you bring the reality of the conversation. It's that he says in the chat, we have to ensure that people understand the government is not using these devices to track them. And that's absolutely the case. These are HIPAA protected devices, only your care team should be using it. But that's actually one of the big benefits of using these medical grade technology versus your smartwatches, which are great for you to get a temporary, just a high level read for a layman's read. But if you really want it to be from a clinical aspect, you want something that's FDA approved, something that's HIPAA compliant, something that goes directly and has security constraints around it so that it is going to your care team and they can actuate on it in an appropriate fashion.
We encountered this situation with our patients when we used remote patient monitoring word. They were scared, so we now try to say remote health monitoring or remote cardiac monitoring, those kind of words.
Yeah, I love that. And I'll say that while I said earlier, one of the barriers removed was stigma, I don't think it was completely removed. I think it's been lessened, but I think that stigma is still always going to be around. And I think that's the case whenever there is new technology, period. And particularly when it's an area like healthcare, where it's so impactful to every person, they become extremely passionate and it makes you a little bit more nervous and scared. So love that. Absolutely, we need to do the best we can to educate all of our patients and our care team to make the patients feel comfortable and confident with the systems and the technologies. So here is something that I find extremely exciting. I think is kind of a wave of the future. That's virtual reality therapy for stroke therapy, for physical therapy, OT, speech therapy, et cetera. It's not only gamifying, as you can see on the left, what it looks like in the clinic, and on the right, what the patient kind of sees and feels within that experience. But furthermore, there's actual data and data science that goes behind it. So as you're wearing the sensors, it actually monitors how far did you reach, what angle, what degree angle were you able to get to. So when I think about building a physical therapy program, I can say on Tuesday in this game, Mitchell was able to reach up to a 70-degree angle. But the next Tuesday, he was able to reach a 76-degree angle. So we know that I'm getting the range of motion back in my arm. And we're now bringing data with this technology to gamify it so the patient gets into the experience of the game, not focused on, well, this should hurt because I'm in physical therapy. They're more challenged with, I want to touch that birdie, so let me go reach. And that's actually what we've seen effects on that. When we think about how else this can be used in the home setting, if we think about these consults for behavioral health, where you can walk a patient through a scenario, whether it's realistic or it's animated, And you as a care provider, or you as the care team member, family member for that patient, can actually watch a different screen and see exactly what they're seeing while seeing their reaction. That can help you a lot. We think about, for me, kids with behavioral health conditions that parents always struggle with. How do I know what makes this kid tick? How do I help them grow and learn with their condition? Was putting them in these different alternate reality scenarios, seeing how they react, and then learning from that yourself while having a therapist coach them through it, I think is one way that we can be extremely innovative in the future downstream. As we think about the typical use in healthcare, we see today that it's already being used where we use Alexa in the surgery centers as kind of your virtual assistant, where Alexa is your checklist. You no longer can make those errors because when you voice and say what's done, it recognizes your voice, it timestamps what you said, and it adds that to the checklist so that it reads back to you what's outstanding on your checklist as your pre-surgical and post-surgical checklist. But it also has that quality control from a safety standpoint where you're no longer taking your gloves off, putting gloves on in the surgical setting because you're talking and saying what you're doing, not physically documenting, allowing you to streamline that focus on what you're doing and bring that clarity around what you need. This other one is robotics assisted telemedicine. So I know we had all this training about a presenter and what they can do. At the end of the day, we want to figure out how do we re-empower the providers virtually so they can feel like they're still driving this consult. And so what this robot allows you to do today, just for familiarity with patients, we still have a presenter that will go and essentially place it near the ear. Once it's nearby, the doctor then takes control on an iPad and essentially moves the image, can zoom in, can zoom out, can tilt it so they can get the exact image that they want to look at and do that full evaluation, really kind of bringing that power back to the provider to take that care using a robot with the technology that we have that we discussed before of presenting that patient. And then further, another one is kind of the use of AI, machine learning, and data science. I think they all go hand in hand when we talk about capturing this data. It's then about how do we summarize that in a usable fashion for the patients, the care team to actuate, really putting that into kind of 3 buckets, 3 bullet points very quickly. The way that I like to think of it is we need to abstract of what all this data is. Otherwise, it's overwhelming for anyone to use and they have to read the whole paper. We want them to just be able to read the abstract and say, okay, I think I know what to do. But if I'm confused on one or don't understand it, let me go into the details of that paper and look at what my trend line is. So that's where I think they can kind of fit together. One that I think is very interesting, particularly with COVID, is drone deliveries. And so there's a system with Zipline. They have this in Africa where they have all of their vaccinations centralized in one warehouse so that it's kept under temperature control and they're able to share those resources as best and not hoard them for any specific location. What they do is have a system that geolocates what's needed, what the orders are, and then they send a drone shipment directly to that facility within 30 minutes that arrives, and then the drone flies back on its own once it's released so that it's back in stock. And so I think that's one way we can really think about how do we use some of that other technology, maybe not specific telehealth, to augment our healthcare systems. And with that, I know we're running low on time, so I'll just say, I always like to leave everything that I present with a challenge for you. And that is that I want us to all think broader. We can't just think about how do we do exactly what we do today, but digitally. We have to think about how does technology create new modalities and pathways for us to be more efficient and deliver higher quality care than what we already do today. And so we need to think about that with efficiencies of scale, population health, right care, right time, right place in mind. I just want to throw out a few quotes that I like to live by, which is work harder, not smarter. And I always believe never start with no, because the answer at the end of the day might be no, not now. But to me, it's if you start with a no, you won't actually explore the opportunity and the value proposition. So always, you can't go back and change the beginning, but you can start where you are and change the end. Love that one. And the only way to discover the limits of possible is to go beyond them into the impossible. And I kind of think that's our duty as healthcare providers for patients to figure out what is that optimal level of care that we can provide today with the tools that are out there. And so finally, I will end with telehealth is here now, it's here to stay, but it's our responsibility to ensure the technology doesn't overtake the human elements and that we're able to focus on getting the patients the right care at the right time and giving our care team the tools to operate more successfully, reducing some of that anxiety, that stress, that burnout, and that burden with the nursing shortage and the physician shortage that we have. Set a goal for yourself. My daily goal, Very simple. Be better today than you were yesterday. That's how I approach every day. And I encourage each of you to set your own daily goal as well as weekly goals. And the last thing I'll say, and this is for me, one of the biggest things in telehealth, is customers will never love a company until the employees love it first. And I think when we think about the stigma with telehealth, that's the passion you need to have around the program if you're trying to develop it. You have to demonstrate that you love the program and you see value in, or your patients will never buy into that. So with that, I know we're right up at time. I'll open up for any questions, and I apologize for us going a little bit over here today.
Great information for us today, Mitchell and team, as usual. Thank you very much. Yeah,